The poisoning, I want to use the word because it's emotive, we can poison our children, can be due to physician error or parent error. I'm going to look at each of these separately. With regard to physician error, we did a study in our emergency room. We looked at about 1,700 prescription orders and tried to analyze whether they were mild, moderate, or severely significant, and some of the factors that were around these errors that occurred. We were quite shocked at the error rate we got until we looked at the literature. We found a 10% error rate in the emergency room, some degree of error. And this wasn't even counting drug orders which were unsigned, undated, or untimed. We could, if we put those in, if you really wanted to be very specific, no drug should be given if it's not date, time, signature, our error rate would have been 60s and 70%. In the busy emergency room atmosphere, many of these things are done orally, verbally, and not countersigned afterwards. This is actually in accordance with other busy areas of hospitals, 6 to 12% error rates in intensive care units. Fortunately, we have nurses, we have parents, and most of these errors are, of course, caught before they occur or are relatively insignificant. In that regard, though, I do want to point out that 35% of the errors that we found, and I think they can be mirrored in other studies, were actually to do with an antipyretic. Using other people's classifications, we divided our error rates into insignificant, significant, and severe, and we had to classify acetaminophen errors as significant because in most cases what had been prescribed or told to the parents were things like, we'll give 15 milligrams per kilogram 4 hourly. If you extrapolate that through, you have a religious parent who gives it 4 hourly, that will be 90 milligrams per kilogram, and that surpasses the daily limit of 75 to 80 milligrams per kilogram for acetaminophen. And if you put that on top of a child who might be a little bit dehydrated, a little bit sick from other reasons, then you can start getting cumulative toxicity. And unfortunately, that is what has been found. I wanted to present this study by Febrile et al. They looked at the published evidence for therapeutic misadventures with paracetamol. And the sources they went to were the published literature. They contacted the FDA authorities in the States and looked at their own hospital. And I'd like to mention that studies, when you get to the range of 40 or 50 patients that you can find in the literature, probably represents the tip of an iceberg. You know, most of us aren't able to study to publish case reports when they're 50 or 60 in the literature. It stops being anything that the journals are going to want to accept from you. So they were able to find maybe 50 patients in which there were some pretty bad outcomes, but I would challenge ourselves that this is the tip of an iceberg, and these therapeutic mishaps happen much more frequently than we think. So they found these 50 patients aged 5 weeks to 10 years of age. Some had been given 60 to 400 milligrams per kilogram per day, remembering that the recommended maximum would be 80. And some had been given for 42 days for fevers of one description or another. In their series, again, tip of the iceberg, 24 of 43 patients died and 3 survived only after transplant. In another study by Rivera et al., this study was conducted in some parts of California, which is a populous state, but it still wasn't a huge population-based study. They looked at patients over a 10-year period in the pediatric age group who'd had an overdose, and here I'm including purposeful overdoses, with previously normal liver function tests. In that group, about 38% went on to have abnormal liver functions tests from their overdose of acetaminophen, and all 28 had severe hepatotoxicity and 6 required transplants. I'm actually mentioning this study for a second reason. 14 of their 73 patients were aged less than 10 years. 71% of these had abnormal liver function tests, and all 10 had been given acetaminophen by mistake in an overdose by their parents. Again, these numbers don't sound really so worrying, but given the number of acetaminophen and ibuprofen dosages which we recommend to our patients, millions and millions all over the world, and we think of this iceberg effect, I suspect that we are causing quite a lot of harm that sometimes, unfortunately, reverses itself, or sometimes just can't be treated depending on the country of origin of the children. I'm only mentioning one study by Tim Olinsky et al., who looked at their own hospital's experience with ibuprofen in simply 1.5 to 2 years. And they were able to document 7 children who presented with diarrhea and or vomiting and fever. They'd been given therapeutic dosages of ibuprofen, and within 1 to 3 days had a degree of acute renal failure, one of whom had to be dialyzed. Again, if this represents one hospital in one city, in one country, and in 20 months, what are we doing to our children that we don't detect? That might reverse itself, or more importantly, it's not detected and the children go on to get severe illness that's not diagnosed, or that just passes in the traffic because there are so many more important things happening in their country or in their life. So what should we do? Educate, 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 educate. Instead of the 1 minute, here's your prescription, leave my office, the parent smiles, you smile, ka-ching, you made your dollar, and they leave in 1 minute, we might have to spend 5 or 6 minutes, and when I teach the residents, I'm telling you the fever talk takes 5 or 6 minutes, which is a long time in an emergency room. I'm sure it's a long time in your practices. But it might need that amount of time, followed up by probably a written pamphlet, to actually talk about fever being a symptom, not a disease, and let's concentrate on the signs of the disease, and that's where we have to spend our time. So what should we educate? Well, my quick in-the-pocket thing that I'm going to try and say to every parent who comes with a child with fever is, it's a symptom, not a disease. The child can have meningitis with a low fever and a cold, upper respiratory tract infection with a high fever. The difference is how sick the child is. And that, Mrs. Jones or Mrs. whatever the name of the parent is, that's what we're going to concentrate on. These are the signs of the illness that you should be looking for. Don't worry too much about the fever, except as it impacts on hydration and general condition. Minimal clothing, naked if possible, just with a diaper, nice cool environment if it's possible, at least somewhere where there's some movement of air, and of course fluids. So, are antipyretics beneficial in febrile children? No. They might make the child feel better, but they cause more harm than good. And I believe antipyretics they're not beneficial in children, and they shouldn't be used.